Fabry disease is an inherited metabolic disorder. Look at this picture, shows that signs and symptoms, multi-organ involvement. Look at this, heart, kidney, then cardiac MRI and renal ultrasound. Look at this for diagnosis, a detail going on. Introduction. Fabry disease is a rare, progressive, X-linked lysosomal storage disorder caused by mutation in the GLA gene leading to deficient activity of the enzyme A glycosides A. This deficiency results in the accumulation of globo-triisoleramide GB3 or GL3 and related glycosphingolipids in the various organs, causing multi-systemic manifestations. Definition. Fabry disease is defined as an inherited metabolic disorder characterized by partial or complete deficiency of alpha galactosides A enzyme leading to the accumulation of glycosphingolipids within lysosomes, particularly globo-triisoleramide GB3. Etymology. Named after Johannes Fabry, a German dermatologist, and William Anderson, an English surgeon who independently described the condition in 1898. Hence, it is sometimes called Anderson-Fabry disease. Epidemiology. Rare disease, estimated prevalence 1 in 40,000 to 1 in 117,000 live birth. X-linked inheritance predominantly affects males, but heterozygous females can also show symptoms due to random X inactivation. Early onset in male childhood or adolescence, later onset in females. Types. 1. Classic Fabry disease, severe enzyme deficiency, early onset, childhood, adolescence, progressive. 2. Late onset, non-classic variant, Fabry disease, residual enzyme activity. Symptoms appear later, third to sixth decade, often cardiac or renal involvement. Dominance. Causes: mutation in GLA gene XQ22.1, deficiency or absence of alpha galactosidase A, accumulation of GB3 in lysosomes, cellular dysfunction. Risk factors: 1. Genetic inheritance, X-linked pattern. 2. Family history of Fabry disease. 3. Males, higher risk of severe phenotype. 4. Female carriers with skewed X inactivation. Complications: 1. Progressive renal failure, end stage kidney disease. 2. Cardiac involvement, left ventricular hypertrophy, arrhythmias, myocardial infarction. 3. Cerebrovascular disease, transient ischemic attack, stroke. 4. Hearing loss, gastrointestinal issues, psychological distress. Pathophysiology. Here is the step-by-step pathophysiology of Fabry disease in a clear flow. 1. Genetic mutation, mutation in the GLA gene on XQ22.1. 2. Enzyme deficiency or absent alpha galactosidase A activity. 3. Failure of substrate breakdown, glycophenolipid, globo triacylceramide, GB3 or GL3, its derivative lyso GB3 cannot be degraded properly. 4. Lysosomal accumulation, progressive buildup of GB3 or lyso GB3 inside lysosomes of vascular endothelial cells, renal podocytes, cardiac myocytes, neurons and other tissues. 5. Cellular dysfunction, enlarged lysosomes, distorted cell architecture, impaired autophagy and mitochondrial dysfunction, oxidative stress and pro-inflammatory signaling increase. 6. Vascular endothelial injury, glycolipid deposition in the endothelial cells, vessel narrow, stiffness and impaired nitric oxide release, result in microvascular ischemia and hypoperfusion. 7. Organ damage progression, including kidney, proteinuria, progressive renal failure, heart, left ventricular hypertrophy, arrhythmias, heart failure. Nerve system, neuropathic pain, stroke, hearing loss, skin or eye, angiokeratomas, corneal verticulata. In short, GLA mutation, alpha gal A deficiency, GB3 lyso, GB3 accumulation, lysosomal overload, endothelial dysfunction, microvascular ischemia, multi-organ damage. Signs and symptoms. Childhood and adolescence. 1. Acroparesthesia, burning, tingling pain in extremities. 2. Hypohidrosis, reduced sweating. 3. Angiocheratosmas, red purple skin lesions, typically in bathing trunk area. 4. Corneal verticulata, overlaid corneal opacity, visible on slight lamp exam. Later complications. 1. Progressive kidney disease. 2. Cardiomyopathy, arrhythmias. 3. Stroke, dizziness, hearing loss. 4. Gastrointestinal issues, abdominal pain, diarrhea. Diagnosis. 1. Enzyme assay, alpha galactosidase A activity, low in males, variable in females. 2. Genetic testing, GLA gene mutation analysis. 3. Biopsy, lysosomal GB3 accumulation, rarely needed now. 4. Imaging, cardiac MRI, renal ultrasound. 5. Biomarkers, plasma lyso GB3 levels. Nursing diagnosis. 1. Chronic pain related to neuropathy. 2. Impaired renal function related to disease progression. 3. Activity intolerance due to fatigue, cardiac involvement. 4. Risk for stroke related to vascular changes. 5. Anxiety and depression related to chronic illness. Medical management. 1. Enzyme replacement therapy ERT, aglycidase beta, fabrazyme, aglycidase alpha, replagal. 2. Chaperone therapy, migalastat for amenable GLA mutation. 3. Symptomatic treatment including analgesics for neuropathic pain, AC inhibitors ARB for proteinuria, antiarrhythmics anticoagulants as needed. Dialysis or kidney transplantation in end stage or renal disease. Nursing management 1. Monitor renal function, urine protein, blood pressure. 2. Educate patient on medication adherence, ERT, chaperone therapy. 3. Provide pain management strategies. 4. Support psychosocial needs, counseling support groups. 5. Encourage genetic counseling for family. 6. Educate on early recognition of complications, stroke, cardio symptoms. Treatment options 1. Disease specific enzyme replacement therapy ERT, pharmacological chaperone, gene therapy, experimental ongoing trials. 2. Supportive therapy, pain management, renal protection, ACE inhibitors, ARBs, cardiac drugs, pacemakers, ICDs if needed, dialysis transplantation. Psychosocial medicine 1. Psychological counseling for coping with chronic illness. 2. Support groups and patient advocacy organizations. 3. Education for patients and families about inheritance and disease progression. 4. Occasional educational support for children and adolescents. 5. Strategies to manage anxiety, depression, and social isolation. Prevention 1. No absolute prevention, genetic disease. 2. Primary prevention, genetic counseling, carrier detection, prenatal diagnosis, pre-implantation genetic testing. 3. Secondary prevention, early diagnosis and initiation of ERT to delay complications. In conclusion, Fabry disease is a rare X-linked lysosomal storage disorder with multi-organ involvement. Early recognition is critical as timely interventions, link enzyme, replacement therapy and chaperone therapy can delay complications and improve quality of life. A multidisciplinary approach involving physicians, nurses, genetic counselors, and psychologists is essential for optimal management. Thank you. Have a nice day.